This is Professor Nicholson lecturing on Complications of Pregnancy, Part 2. Please review Unit 5, Module 1 subcompetencies on your own. Please note that some subcompetencies are in Part 1 and some are in Part 2. Just a review on diabetes mellitus. Type 1 is insulin deficiency due to autoimmune beta cell destruction, and type 2 is insulin resistance or deficiency due to progressive loss of beta cells related to obesity and sedentary lifestyle. Gestational diabetes is glucose intolerance during pregnancy. It's important to know that pre-gestational diabetes is in regards to expectant mothers who are already diagnosed with diabetes prior to pregnancy. They may see fluctuations in their glucose levels and insulin needs. It's important to maintain healthy blood glucose levels prior to conception, and poorly controlled diabetes early on in pregnancy can be linked to pregnancy loss. Pregnancy is a stress test for the body's glucose hemostasis mechanism. During pregnancy, peripheral resistance to insulin increases, but in response, insulin secretion also increases. Risk factors for developing gestational diabetes includes pre-gestational diabetes, physical inactivity, first-degree relative with diabetes, hypertension, a smoker, as well as obesity. You need to know how somebody is diagnosed with gestational diabetes. So during pregnancy, around 24 to 28 weeks gestation, the office does a 2-hour glucose tolerance test. It's a 75-gram oral glucose load that is given, typically in a drink form, whether that be orange, lemon, fruit punch, whatever they got there. Blood glucose levels should be less than 120 milligrams per deciliter at 2 hours. With this test, patients typically have to fast for so many hours until then. If this glucose test fails, a 3-hour glucose test should be given. At this point, blood glucose levels should be less than 95 milligrams per deciliter at 3 hours. The following are glucose levels during pregnancy. Checkpoint. So what does the nurse anticipate if a patient's 2-hour glucose tolerance test is 165 milligrams per deciliter? Well, further testing would need to be given because this glucose level should be less than 120 milligrams per deciliter. The next test, as I mentioned in the previous slide, is that 3-hour glucose tolerance test, and this one should be less than 95 milligrams per deciliter. Therefore, if that one fails as well, the patient is diagnosed with gestational diabetes. One of the most important complications to remember in regards to gestational diabetes is that ketoacidosis due to uncontrolled hyperglycemia increases the risk for stillbirth. Other complications include polyhydramnios, UTIs, macrosomia of the fetus, so a fetus that is large, postpartum hemorrhage, as well as maternal risk for development of type 2 diabetes later in life. The first line of gestational diabetes management involves diet and lifestyle changes. The second line of management involves pharmacological treatment. This includes insulin, which is a medication of the provider's and patient's choice, and this does not cross the placenta. Glyburide is an oral medication, and this also does not cross the placenta. Nursing management of gestational diabetes. The goal of blood glucose level should be 110 milligrams per deciliter during labor and delivery to prevent neonatal hypoglycemia. The patient has their glucose levels monitored frequently during their labor, and in some cases an insulin drip is required during their labor. Following delivery of the baby, insulin requirements drop and risk for hypoglycemia is present in the newborn as well as the mother. The newborn is used to hyperglycemia from the mother, produces insulin in response to hyperglycemia, and following delivery, glucose levels drop, and insulin levels still are high. That is why the newborn is at risk for the hypoglycemia. Blood sugar checks will be performed on the newborn per unit policy due to this risk. Group B streptococcus, also GBS. This is not the same strep that people think of with the throat. GBS is a naturally occurring bacteria found in about 50% of healthy adults that colonizes in the gastrointestinal and genitourinary tracts. About 50% of pregnant women carry GBS in their rectum or vagina, which introduces the risk of exposure to the newborn following delivery. GBS commonly causes sepsis and meningitis in exposed newborns. GBS management. Pregnant patients should be screened for GBS between 35 to 37 weeks gestation. This screening is a lab specimen that's collected by swabbing from the vagina all the way down to the rectum. During labor and delivery, GBS-positive mothers are treated prophylactically with antibiotics. Penicillin is the treatment of choice and should be administered at least 4 hours prior to delivery. It's important to understand that patients with this allergy may need a different type of antibiotic, so be cautious with your patient's allergies, as you always should. It's important to note the time of rupture of membranes for patients who are Group B strep positive. Rupture of membranes greater than 18 hours increases the risk of exposure. You should watch for signs of infections such as fever, and many patients remain asymptomatic, but some may develop UTIs, uterine infections, as well as chorioamnionitis, which is an infection within the amniotic fluid. Checkpoint. Why are antibiotics not started as soon as a patient tests positive for Group B strep? Why wait until labor? This is because antibiotics are ineffective if given during pregnancy because recolonization is possible. Toxoplasmosis. This is a parasitic infection caused by Toxoplasma gondii. It's most commonly found in cat feces, like in the litter box, but it's also tied to undercooked meat, contaminated water, and contaminated soil. Pregnant women who contract toxoplasmosis are at risk for harm to the fetus, and this includes congenital defects, preterm labor, and stillbirth. For exposed patients, an anti-parasite and an antibiotic are used. So, you need to know your patients should not be changing their kitty litter box. Hepatitis B is one of the most prevalent chronic diseases in the world. It's transmitted through contaminated blood, illicit drug use, and sexual contact. It can cause liver failure in exposed individuals. Expectant mothers who contract hepatitis B during pregnancy put the newborn at risk for developing chronic hepatitis B. Hepatitis B management. During pregnancy, all patients are screened for risk factors associated with hepatitis B and tested for the hepatitis B surface antigen. If a mother is positive, newborns will not only receive the hepatitis B vaccine, but also hepatitis B immunoglobulin, HBIG, within 12 hours after birth. Rubella, aka German measles, is an infection spread through droplets and contaminated surfaces. If contracted during pregnancy, risk of transmission to the fetus is high, resulting in cardiac defects, microcephaly, and other disabilities. Most patients will be vaccinated prior to pregnancy, and a titer level will be checked to determine their immunity. Patients who are rubella not immune will be vaccinated following delivery and should be educated on how to prevent exposure. This includes avoiding anyone who has a fever and a rash. You need to know that. Vulnerable populations. This includes pregnant adolescents and advanced maternal age. Pregnant adolescents are between the ages of 11 to 19 years. They're the least likely age group to attend prenatal appointments, and this places them at an increased risk for complications. Support such as emotional and financial resources, are a priority for pregnant adolescents. In regard to advanced maternal age, this is anyone over the age of 35. No, we are not old. This is an increased risk for gestational diabetes, gestational hypertension, SGA, preterm labor as well. Close prenatal monitoring is very important. Overall, lifetime and 1-year estimates for sexual violence, stalking, and intimate partner violence are alarmingly high for adult Americans. On average, 20 persons per minute are victims of rape, physical violence, or stalking by an intimate partner in the United States. This equates to more than 10 million men and women. Pregnancy is a time of unique vulnerability to intimate partner violence, also known as IPV, victimization, because of changes in a woman's physical, social, emotional, and economic needs during this period. Although the true prevalence of violence during pregnancy is unclear, research suggests it is substantial and often continues into the postpartum period. All pregnant women should be screened for violence at every single visit, when they are alone, of course, and be provided with interventions and referrals to services if needed. That is why this is part of this pregnancy complications lecture. During the first, and usually the longest, phase of the cycle, tension escalates between partners. Excessive drinking, jealousy, or other factors might lead to name-calling, hostility, and friction. In her mind, if she does her job well, they remain calm, but if she fails, the resulting violence is her fault. Phase 2 is the physically abusive phase. The second phase of the cycle is the explosion of violence. The abuser loses control both physically and emotionally. This is when the victim may be assaulted or murdered. After a physically violent episode, most victims consider themselves lucky that the abuse was not worse, no matter how severe their injuries. They often deny the seriousness of their injuries and may refuse to seek medical treatment. Phase 3 is the honeymoon phase. The third phase of the cycle is a period of calm, loving, and contrite behavior on the part of the abuser. They may be genuinely sorry for the pain caused to the partner. They attempt to make up for the brutal behavior and believe they can control the violence and will never hurt the woman again. The victim wants to believe that her partner really can change. She feels responsible, at least in part, for causing the incident, and she feels responsible for her partner's well-being. Frequently, the fear of harm to a pregnant patient's unborn child will motivate them to try to escape an abusive relationship. Pregnant women are at an increased risk for violence. Women abused during pregnancy are at an increased risk for the following. Domestic violence nursing management is imperative. Screen for abuse at every visit and try to get them alone. Injuries, mental health problems, STIs, nervous appearance, and an overprotective partner and one who speaks for the patient are all signs that a patient could be dealing with domestic violence. Isolate the patient if abuse is suspected. Ask questions. Direct questions, not indirect questions. Direct questions that concern your suspicions need to be enforced. Think about the patient's safety. Patients are at a very, very, very high risk when they try to get help. That is why they should be isolated when abuse is suspected. This is a great mnemonic for nurses to understand when trying to care for an abused woman. A is reassuring the woman that she is not alone. The isolation by her abuser keeps her from knowing that others are in the same situation and that healthcare providers can help her. B is expressing the belief that violence against women is not acceptable in any situation and that it is not her fault. Demonstrate by your actions and words that you believe her disclosure. C is confidentiality. Since the woman might believe that If the abuse is reported, the abuser will retaliate. Interview her in private, without her partner or family members present. Assure her that you will not release her information without her permission. D is documentation, which includes a clear quoted statement about the abuse in the woman's own words, an accurate description of injuries and the history of them, information on the first, the worst, and the most recent abusive incident, as well as photos with the woman's consent, of course. E is education about the cycle of violence and that it will escalate. Educate them about abuse and its health effects. Help her understand that she's not alone. Offer appropriate community support and referrals, and display posters and brochures to foster awareness of this public health problem. And lastly, the biggest priority of all is safety. This is the most important aspect of the intervention, to ensure that the woman has resources and a plan of action to carry out if and when she decides to leave. Checkpoint. A nurse is working with a victim of intimate partner violence, helping the client develop a safety plan. Which items would the nurse suggest that the client take when leaving? Select all that apply. The answers here are A, driver's license, B, social security number, C, cash, and E, health insurance cards. When leaving an abusive relationship, the victim should not take a phone card because this can actually leave a trail for the partner to follow. The United Nations defines human trafficking as the recruitment, transportation, transfer, harboring, or receipt of persons by means of the threat or use of force, abduction, fraud, or deception to achieve the consent of a person having control over another person for the purpose of exploitation. Nurses are one of the few groups of professionals likely to interact with trafficked victims while they are still in captivity. They have the opportunity to screen, identify, intervene, and rescue these victims. Nurses are well positioned to identify and assist trafficked individuals as well as those who may be at risk for exploitation. Victims are exposed to serious and numerous health risks, as stated in this slide. The following are nursing assessment questions you should ask yourself if you feel that you have a patient that is dealing with human trafficking. Nursing interventions include building trust, which is the top priority. Again, this one is the top priority. You should know the at-risk groups, as I mentioned in a previous slide. Observe the relationship between the patient and the accompanying person. Take the time to listen and develop a rapport with the patient. Look at them when they're talking. Don't look at your computer screen. Actually communicate with them. Screen them in a private place. You want to provide them reassurance. Provide one-on-one interactions. Like I said, isolate them. Examine every single injury that they could have. Assess their hydration, nutrition, and hygiene status. Do not reply on a patient's interpreter. You need to use the hospital's interpreter. Specifically ask about the client's safety. Be direct, do not be indirect. Offer paraphrased stories to clarify as well as therapeutic reflection. Stay calm when speaking to them. Document your suspicions in your notes. Like I said, listen to them. Try to keep it all in your mind. You really want them to be your focus when you're sitting with them. And make sure that they understand the hotline for guidance. Look beneath the surface and ask questions such as the ones on the slide. Nurses are well positioned to identify and assist trafficked individuals as well as those who may be at risk for exploitation. If you suspect a trafficking situation, notify local law enforcement and a regional social service organization that has experience in dealing with trafficking victims, such as the social worker that's on the unit. It's imperative to reach out to these victims and stop the cycle of abuse by following through on your suspicions. I always say, listen to your gut. Nurses can also reach out within their communities to bring out awareness through community education to human trafficking, to uncover the hard truth about it to our nation's blind eyes.